When people think about surgery, they usually worry about the surgery itself. Will the procedure go well? Will there be complications? Will they recover physically? But there's another phenomenon that has quietly concerned doctors and patients for decades. Some people undergo surgery and afterward they never quite feel mentally the same again. They describe brain fog, memory problems, difficulty concentrating, confusion, slower thinking, sometimes even personality changes. This is often referred to as post-operative cognitive dysfunction or post-operative delirium. And it happens especially often in elderly patients. Now, modern medicine usually explains this through things like inflammation, stress hormones, the effects of anesthesia drugs, age-related vulnerability, or tiny vascular injuries. And all of these things probably matter, but there may be another overlooked factor hiding in plain sight. And this is, of course, carbon dioxide. More specifically, what happens when too much carbon dioxide is removed from the body during surgery. Because during anesthesia, patients are often mechanically ventilated. And historically, many patients were ventilated quite aggressively, meaning they were essentially over-breathing through the ventilator. And when you hyperventilate someone, you blow off carbon dioxide. Now, most people think of carbon dioxide as merely a waste gas. But physiologically, CO2 is one of the most important regulators in the human body, especially in the brain. In fact, carbon dioxide is one of the strongest regulators of cerebral blood flow that we know of. When CO2 levels rise, blood vessels in the brain dilate, blood flow increases, oxygen delivery improves. But when CO2 levels drop, the opposite happens. Cerebral vessels constrict, and this can happen very rapidly. Even a modest drop in arterial CO2, from 40 millimeters of mercury down to 30, can reduce cerebral blood flow by roughly 20 to 30%. Think about that for a moment. A patient can have perfect oxygen saturation, tons of oxygen in the blood, yet significantly less blood reaching the brain itself. This creates a fascinating physiological paradox. High oxygen, low CO2, tight cerebral vessels, and potentially reduced oxygen delivery to neurons despite excellent oxygenation on the monitor. Because oxygen in the blood is not the same thing as oxygen reaching the tissues. And this becomes even more important when we talk about the Bohr effect. The Bohr effect describes how carbon dioxide helps hemoglobin release oxygen into the tissues. Lower CO2 causes hemoglobin to hold onto oxygen more tightly, meaning during hypocapnia, which simply means low CO2, oxygen unloading can actually worsen. So now imagine the situation during surgery. The patient may be receiving very high oxygen concentrations, sometimes 80 to 100% oxygen, while simultaneously being hyperventilated. So what happens? You may end up with less cerebral blood flow and less oxygen unloading, and paradoxically, poorer tissue oxygenation delivery, especially in the vulnerable brain regions like the hippocampus, the frontal cortex, and watershed vascular areas. But there's another layer because hyperoxia itself, meaning excessive oxygen exposure, may also create oxidative stress. During surgery, patients are being exposed to mechanical ventilation, high oxygen, immobility, and anesthesia-induced mitochondrial suppression. And excess oxygen can increase reactive oxygen species, lipid peroxidation, endothelial dysfunction, and mitochondrial stress. The brain is particularly vulnerable because it has extremely high metabolic demand, large amounts of lipid-rich tissue, and a constant need for blood flow. So now combine hyperoxia with hypocapnia-induced vasoconstriction. You potentially get less perfusion, more oxidative stress, and impaired metabolic coupling. That combination is theoretically very problematic. And low carbon dioxide doesn't just affect blood vessels, it also directly affects brain activity itself. Low CO2 changes pH, ion channel behavior. calcium signaling, and cortical excitability. Even healthy awake people who hyperventilate can experience dizziness, confusion, tingling sensations, panic, visual disturbances, and impaired cognition. Overbreathing alone can alter consciousness. Now imagine the brain under anesthesia, already stressed, already vulnerable, already metabolically altered. And now cerebral blood flow is being reduced even further by low CO2. One of the people who strongly argued this point is a good friend of mine, Dr. Lewis Coleman, author of 50 Years Lost in Medical Advance. Coleman believed that excessive ventilation during surgery was particularly dangerous, especially in elderly patients. His reasoning was actually very physiologically coherent. Older individuals generally produce less carbon dioxide metabolically than younger people. They also tend to have reduced vascular reserve, impaired autoregulation, less resilient circulation, and greater vulnerability to neurological stress. So if you ventilate an elderly patient aggressively, you may drive their CO2 levels down very quickly. Coleman believed this could contribute to reduced cerebral perfusion and post-operative cognitive problems. He reportedly attempted to avoid excessive ventilation and sometimes used fentanyl to suppress overbreathing and allow CO2 levels to remain higher. Now, to be clear, this is not medical advice. Opioids can be dangerous. Respiratory suppression can become life-threatening if handled improperly. Ventilation management during surgery is extremely complex. But the underlying physiological principle is important. And increasingly, modern anesthesia literature is beginning to question aggressive hypocapnia. Historically, hyperventilation during surgery was very common. But today, there's growing recognition that low CO2 may reduce cerebral perfusion and worsen neurological outcomes in some patients, especially elderly patients, cardiac surgery patients, neurological patients, and critically ill patients. Some studies have even associated intraoperative hypocapnia with increased post-operative delirium risk. So the concern about low CO2 is absolutely present within mainstream anesthesiology discussions. And perhaps one of the most interesting ideas here is what we might call silent ischemia. An awake person who hyperventilates experiences warning symptoms. They feel air hunger, dizziness, panic, reduced consciousness. The body tells them that something is wrong. But under anesthesia, the patient cannot feel any of this. They cannot respond. They cannot slow their breathing. They cannot signal distress. So it is conceivable that prolonged mild cerebral hyperperfusion combined with oxidative stress, combined with inflammation, could contribute to subtle neurological injury. Not necessarily a stroke, but enough to impair memory, attention, processing speed, and executive function afterward. And perhaps that is part of the reason why some patients say, I recovered physically, but mentally I never felt the same. Now, none of this means oxygen is bad, anesthesia is unsafe, or surgeons are harming patients. Modern anesthesia saves lives every single day. But it may mean that carbon dioxide physiology is far more important than we've historically appreciated. Because the body simply doesn't need oxygen present, it needs oxygen delivered. And carbon dioxide plays a central role in making that happen. Perhaps one of the most overlooked molecules of medicine is also one of the most important. And perhaps the future of medicine will involve not just asking how much oxygen is in the blood, but also how well is that oxygen actually reaching the tissues. For more on the science of carbon dioxide and human physiology, explore my new book, The Carbonated Body, which can be found on Amazon.